At the heart of medical excellence lies the power of knowledge and hands-on training. Welcome to the JROP Institute of Echocardiography, Ultrasound and Vascular Doppler, where innovation meets expertise. For over 25 years, we've empowered healthcare professionals with world-class training, guided by experienced mentors and real-time practice, advancing medical training in echocardiography and ultrasound, ensuring precision, confidence, and care in every diagnosis.
Good evening, everybody. Welcome to this 53rd comprehensive course on echocardiography. We are in 11th session today, that is on 17th June 2026. We have covered two sessions of mitral valve and aortic valves, pulmonic and tricuspid valves, as far as stenosis is concerned. Today, we are going to talk about another session of valves that is consisting of mitral and aortic regurgitations. How do we do it, and how do we assess the pathophysiology? We are from Drop Institute of Echo, Ultrasound and Vascular Doppler, Delhi, with many accreditations right from Indraprastha University, which is the latest recommendation, and yours is the first batch to get accredited. And I'm sure shortly you're going to get your roll numbers from this particular university. We can boast of saying that we are the longest running residential program in India in private sector since April 2000 without any single break. And more than 5,000 people have attended this program in last 25 years. And we always make efforts to make one program better than others. These people who have attended our program, many of them have risen to director non-invasive cardiology in major cardiovascular hospitals. And we have a long list of countries from where internationally people, they come and participate in these programs. And latest entry is a Caribbean island from West Indies. We started this program, especially this one, 53rd fellowship program of Echo in Basics from Jorab, and the first fellowship program of Guru Gobind Singh IP University, Delhi. And originally, we started this program in April 2000, almost 26 years of existence. With this few words, let me move on and talk about the third session on valves, that is mitral and aortic regurgitations. And I'm Dr. Rakesh Gupta, who's going to take this particular talk today on evaluation of mitral and aortic regurgitations. Let me switch on my gears from this particular presentations to another one where I can Well, as far as mitral regurgitation is concerned, you will realize that we have to understand many things for as evaluations. And before we start evaluation, why we need to evaluate their regurgitations? Because as the severity of mitral regurgitation increases, so is the mortality and morbidity. Surgical correction of mitral regurgitation is highly successful today. And I can say that structural correction by using a non-surgical technique has been found to be very effective in certain cases. The operative risk of valve repair and replacement is quite negligible, and surgery is considered to be one of the modality now. I can say that it's not the only modality, one of the modality for severe mitral regurgitations. I'll tell you all these modalities when I'm dealing with this particular phenomenon. Look, it could be symptomatic or it could be asymptomatic. And this is a graph which is almost 20 years down the line for a survivability. You have an onset of mitral regurgitation, the LV starts dilating, the LV dysfunction set in, and till the time patient develops a symptomatology, the graph of survival is pretty flat. But as soon as the patient develops a symptomatology like dyspnea, syncope, chest pain, the mortality rate rises dramatically. So we need to pick up these people before they become symptomatic or the LV starts dilating. And that is the time we can give them a best treatment. Moving on further, this is a slide which is again 20 years or more in slide. The event-free survival in patients with no MR versus severe MR. So higher the severity of MR is, the real answer is like we have a poor prognosis. It does not make any difference on the survival because of ejection fraction, whether it's normal or low. If you have a higher degree of regurgitations or significant symptomatology, their mortality rate is pretty high. And this is one slide which is quite useful for our country, especially in people who are presenting with asymptomatic organic mitral regurgitations. And these people, when they present with asymptomatic, I'll be showing an example for that. You look at their LA volumes. If the LA volume is less than 55 ml per meter body surface area, the cumulative mortality is much lower as compared to the people who have got LA volume index of more than 55 ml per meter square. And if you can believe, I can show you a patient like whom we have been following for more than 25 years with his severe MR organic, but he's asymptomatic and LA volume is still less than 55 ml per meter body surface area. A word about mitral valve anatomy. We did discuss about all these things, but I have just taken a few slides from a literature because I was preparing this. And as you remember, like last time when I said, like people were asking the ASD and mitral stenosis, how to evaluate them. During that time, I did make a few slides, and those slides I have sent it to all of you. When we look at these mitral valve apparatus, there is smooth zone, which is considered as the body of the leaf, body of the valve. And there's a coaptation point, which is known as rough zone. So you can have a problem either with a smooth zone or a body, or you can have a problem with a coaptation point, which is a rough point. Why do we say a rough point? Because rough point is the point where the flow happens through the valve leaflets. And this is very important because coaptation preservation versus coaptation loss makes a lot of difference when we're talking of mitral regurgitations. Now moving on further, this is again zoom up slide. This is the body of a leaflet, which is known as smooth zone. And this is a leaflet points together, which is known as coaptation point or a rough zone. Well, we do classify mitral regurgitation into three different varieties. One is primary or secondary MR. Second is a Carpentier classification. Third is acute versus chronic MR. Well, primary and secondary are two different pathologies. Acute and chronic are two different pathologies. So let's start one by one. What the primary MR is? All myxomatous degenerations of the leaflets. Mitral valve prolapse, other things. Then atherosclerotic valves. Infection of the valves like endocarditis. Then we have number of people presenting with rheumatoid heart disease, inflammatories, then congenitals. So all these kind of a drug, which is rheumatic, rheumatoid, they all together consist of an infection, inflammatory, and then congenital like cleft mitral valve leaflet or a parachute mitral valve leaflets. Something to do with the pathology of the mitral valve per se. Then we have ischemic mitral regurgitation, that is secondary to coronary disease like LV start dilating. Because of ischemic heart disease, it could be because of a non-ischemic like dilated cardiomyopathies. And then annular dilation for various reasons. So let's talk of a myxomatous degeneration. Here is a patient who has got a floppy mitral valve leaflet. Look, this how big these leaflets are. And this AML is prolapsing, is not prolapsing, is flailed back into the LA. And now I can say very well, safely, like when we talk of this leaflet is this one tip, this is the second tip. And now remembering this tip in that particular diagrams, let me just pick up this tip for you. It'll take me a second. Now compare these two important images. So this is AML, this is PML. This is PML, this is AML. Look, the leaflets, they are not co-opting with each other. It's this tip of the leaflet is billowing back into the LA. And this is what is known as flail mitral leaflet. The cooptation point is lost. And today, like if you really ask me 10 years down the line, and today the management of these leaflets are, in 10 years down the line, we were doing a mitral valve repair surgery, open mitral valve repair surgery. If you ask me this patient in 2026, what is the management? Mitral clip, transcutaneous edge-to-edge repair. And we have seen many people presenting with this kind of a flail leaflets and getting a tear done and almost recovered to normal without any surgical scar. And that's what has changed in the last 26 years. Another example of flail leaflet, let me just now, it'll be more easy for you to understand. People often ask me, why do you do all these things during the class? I say, we are doing a class, we are not like going to a conference. We have to teach them what is really important is. And now you can realize the two important images lying close to each other. Now, this leaflet, this is one leaflet, this is second leaflet. This leaflet point is billowing back into the LA. And when it's billowing back into the LA, this eccentric jet which is always present. And that's what the real example for this cooptation point. And this is the body of a smooth zone. If you have this body of the leaflet versus this cooptation point is more dangerous than the body of the leaflet. Another example, you saw AML was prolapsing. Now, PML is flail. The direction of the jet is towards the LA side, LA intra-atrial septum side, or towards aorta. So, direction of jet will be based on the kind of a leaflet flail or a prolapse. Very good example now. Now, this is the right time to make you understand what exactly I was trying to say for last couple of minutes. Now compare these two slides. This is a 3-dimension echo. This is a picture. Look, this is leaflet body. This is a tip. This is a tip, and this is a leaflet body. And let me stop this slide. Correct. Now this point is cooptation point is lost, and this leaflet is flame going back into the LA. There's no cooptation. Now see again. Correct. This is one point, this is second point. They're way away from each other. And this is known as exactly the flail mitral valve leaflet. And in this patient, this is A2 leaflet, this is P2 leaflet. This is how we say the flail leaflet. And when we look at these kind of leaflets, we used to talk of a surgery 10 years down the line. Now we are talking of a mitral clip or a tear procedure for their recovery. Degenerative, all of us understand what the degenerative leaflet is. We have thickening and calcification. There is no doming of the leaflet is. But there's a lot of mug or a calcium on these AML as well as PML and interventricular septum also. This is mitral calcification. A lot of smug is placed on this. This is mitral calcification. Now, this is another example of degenerative mitral calcification. This is a transesophageal echo. This is LA, this is LV, this is aorta over here. And this is A2 scallop, this is P2 scallop. And you see a significant mug. Sorry, this is A2 scallop, this is P2 scallop. This significant mug on the PML calcifications. Degenerative will give rise to eccentric jet again, but there will not be any significant prolapse or a thickening. Next is infective. Now, if you look at the degenerative mitral, so like what do we do with this degenerative? The only answer with this degenerative leaflet is either do a medical management, and if they're symptomatic, you have to replace the valve. Next is infective. This is a neonatal fungal endocarditis. How big the masses are. It's the Candida albicans. Another example, like funny, atypical kind of a mobile echo density which is present on these leaflets. Whether this is mass or this mass, the answer is surgery. Now this is multiple infective endocarditis. You can see a vegetation on the AML. You can see a vegetation on the aortic valve. And this is another classical example. Look, this is a coaptation point, but patient has got a perforation in the AML leaflet. Again, surgery. This is another aneurysm of the mitral valve, AML aneurysm. And how do we differentiate from abscess? If you switch on the colors, I hope the colors will come. Yeah, colors are there. If you happen to see a colors into this aneurysm, if you have some abscess, there will not be a color inside the aneurysms. Now you compare side by side. So you can see a colors over here. There's a three-dimensional picture over here. And this is two-dimensional picture of the same patient. Answer, surgery. This is very another variety of MR, where you see a masses in the apex, you see a thickening of the leaflets, and this is what classical example of hypereosinophilic syndromes. Treatment, obviously, steroid with dihydrocarbamazine. Valve dehiscence. I'm sorry I couldn't get a valve dehiscence today. We just recorded a very beautiful valve dehiscence in our center. Hold on a second. If I can see that valve dehiscence, it's excellent valve dehiscence which recently saw in the center. Yes, I could locate it. Give me a second. I'll just shoot it for you. Now, this is a 3D image of a patient. This is the mitral valve. This is all sewing ring which we can see over here. And look, there's a gap, some gap over here. And if I switch on the colors, now look carefully. There you find the colors over here rather than the colors only in this particular area. And this is very well seen in this leaflet over here. Here is the leakage of the paraprosthetic valve. So this is what is important. Now you can see as much better. This is the valve, and here is the whole paraprosthetic leak which is happening. Now see it again. Can you see this paraprosthetic leak? So this is what exactly the answer for this paraprosthetic leak is. Now other zoom view of the same patients. You can see a paraprosthetic leak over here. Now you can see all around the leaflet there is a leakage. This is not a regurgitation, it's a variety of where the suture rings gives way. That is paraprosthetic leak. And
Sir, no,
if
sorry,
you
sir, I'm not able to see anything, sir. So your screen is freezed.
okay,
स्क्रीन फ्रीज हो गया कुछ नहीं दिख रहा है
just give me a second. I'll try. Now you're able to see it?
No,
नो
sir,
सर
not yet, sir.
Not now?
No, sir.
नो सर
Oh, sir.
Okay, let me try again.
Yes, sir.
Yes, now visible, sir.
Can you see now?
Yes, sir.
Yes, sir.
Yes, sir.
So this is all paraprosthetic leakage. So this is transesophageal 3D echo. This is a valve, and here is the space through which the blood leaks. And this patient was diagnosed as severe mitral regurgitations. Now you can see the leakage in this particular part of the valve over here. Now you can see it's much better. Whole of this area is leaking right now. So my quest of showing this particular slide was, like, when you look at this mitral regurgitation, you have to try to understand what is the cause of this leakage is. So that is wall Dyson's. This is a wall Dyson's which we saw about 20 years down the line. This is 2002. And this is what valve Dyson's we are seeing now. And the management of this valve Dyson's is, the only answer for management is again redo surgery or we put an employee's device. So the question of showing these slides is, like, what is the cause of these leakages? Fortunately, this has come again. What is the cause of these leakages are? This is another patient of valve Dyson's. This is prosthetic mitral valve degeneration. Look, this valve has got 3 leaflet studs, 1, 2, and 3. Now, if you look carefully, once this stud is gone, it has been eaten away by bacteria or it has degenerated. So we could see only one stud over here. And that is Hancock 2, which has really degenerated. So when you happen to see a primary pathology, that is what is primary reason for NMR. Now, second is rheumatic or inflammatory. So this is rheumatic heart disease. This is the commonest presentation which you see in your life is thickened leaflet. They are fixed, they are calcified, they have a flail leaflets, and they have a restricted motions, and either they are stenotic or they are leaking. This is the commonest presentation of a rheumatic heart disease. Then congenital. Look, there's a cleft of AML. By birth, the leaflet has got a cleft. Again, a transesophageal echo from a same R lab is. Then we have parachute mitral valve. This is like mitral valve looks like as it is, but look, there's no only one papillary muscle is present on the lateral one. The inferior one is not there. Then ischemic pathology. How does the ischemic pathology? You develop a severe aortic mitral acute MI. So what happens? The mitral valve, the teeth ring effect happens, and the mitral valve starts leaking. Now, if you look at this mitral valve regurgitation, what do? You're not going to fix up this mitral valve by doing a mitral valve surgery. You have to fix up the acute myocardial infarction to fix up the mitral valve. Same patients, when they become longer for a long time, chronic ischemic effects, they develop a dilated LV and mitral regurgitations. Some people may not have any valvular multi. The ischemia of the papillary muscles give rise to severe mitral regurgitations. And it's a very good example. If you suspect ischemia, your lead ECG shows lead 2-3 AVF V2 to V6 ST segment depression or TVF inversion. You do an echo, you don't find any valvular multis, but you find a severe mitral regurgitation. Regurgitation, which means there's a papillary muscle which is attached to lateral wall of this particular image, has become ischemic. And that lateral wall ischemic, lateral papillary muscle ischemic means it has got a severe mitral regurgitations. And how do I compare this? You must have seen a tent in older times in the marriages. These tents were fixed in the ground with a kind of wood which used to be dug inside, and there was a rope with which you should tie the tent. So this wood is papillary muscle, the rope is a cordage. And in fact, you suspect this particular phenomena, patient give him a sorbitate. And if it is ischemic, the MR will reduce or disappear. So you got an exact answer why this mitral regurgitation is present. And again, the treatment of mitral regurgitation is not what? Mitral valve repair. No, it's a management of ischemic mitral regurgitations. Then non-ischemic, LV start dilating, dilated cardiomyopathies. Very common example in diabetic populations today. Patient presenting four-chamber dilatations and dilated cardiomyopathies. Coronaries are normal. Annular dilatation. Atrial fibrillation is a commonest example for annular dilatations. Because LV and LA, they are behaving incoherently, like discordant husband and wives. Then special variety. This is a very interesting picture. What we call them is a Conda effect. Patient has got a severe mitral regurgitation. It has got a severe MR jet, which is hitting back to the pulmonic and wrapping out and going back into the LA. Now look at carefully. This whole MR jet is wrapping back and going into the LA. My request is please silent your mic. The kids are saying something on the mics. So this is when we have a severe mitral regurgitations, and we call them as Conda effect, when the jet wraps around in the LA and goes back to the mitral valve. You can see this mitral valve now in fixed position. Then the severity of mitral valve can be judged by truncation of the systolic flow of the pulmonic vein. Look, in this patient who has got a severe mitral regurgitation, you do not see any systolic flow in pulmonic veins. Normally, pulmonic veins have the S wave and a D wave. It's a continuous flow, but you don't see, only you see a diastolic flow. Presence of a diastolic flow in pulmonic veins is suggestive of severe mitral regurgitations. Another example, this is secondary mitral regurgitation. The jet wraps around the valves, which is known as splay. This is not mild, this is severe, but it wraps around the leaflets. This is mitral secondary splay. And how do we find it? We always put a transducer inside, a T probe inside, and look for a severity of mitral regurgitation. Then, this is what often people ask, what is the kind of MR, the classification for management points? Type 1 is when we have normal leaflets, like patient has got an angular dilatation or perforation. Type 2 is when we have excessive movements, normal, excessive movement, and restrictive movements. Excessive means flare and prolapse, myxomatous valves. And restricted movements is when you have a thickening and fusion of the valves or LVLA, they start dilating, then it is a classical example for dilated cardiomyopathies. Last, acute versus chronic. Acute is when sudden trauma happens, caudal rupture, infective endocarditis, papillary muscle rupture, papillary muscle dysfunction due to ischemia, acute myocardial ischemia, acute rheumatic fever with carditis, acute cardiomyopathies, prosthetic valve degeneration presenting as acute mitral regurgitations or paraprosthetic leaks. What is like when we say acute versus chronic? Because acute patients, suppose you have developed a caudal rupture, patient will not present with the MR, patient will present with acute LVF. L is not tuned to that particular pressures of sudden unloading of LV to LA pressures. Normal LV pressure is 120, the LA pressure is only 10 to 15. So acute MI, and here's the differences. Acute mitral regurgitation has a cardiac output that gets reduced. Suppose it's acute MI, the output will reduce. Ejection fraction could be normal or start reducing. Here in chronic, the ejection fraction may increase. And diastolic pressure is significantly high in acute. They could be normal in chronic because compliance have become, there was non-compliant, now it's become compliant. So left atrial compliance would be poor or low normal. Here it will be increased to accommodate that large amount of blood into the LA. And left ventricular size in acute would be normal. LA-LV size would be normal. But in chronic, LA-LV size will start increasing. And in fact, when we talk about severe mitral regurgitation, LA size is one of the most important criteria. Now let's come down to features with which we say a severe mitral regurgitation. If it's acute, normal LVLA size, that's the first most important thing is. You look at a vena contracta more than 7 millimeter. You look at systolic pulmonic venous flow pattern, blunted or reversal. Decreased aortic valve opening, Disrupted mitral apparatus, normal LV size and functions, and we can add safely the normal LA size. Then, what is the answer? If you have a myxomatous valve, surgical correction or mitral clips. Degenerative, surgical repair or replacement. Others like dilated annulus or ruptured cords, we have been trying to do a mitral clips in these subset of populations. Now, the true topic, how do we assess mitral valve regurgitations? Before than that, we have to understand why we are looking at the mitral regurgitations, for what reason we are looking. In acute, you will not find many of these things. But in late or a chronic, you will find palpable cardiomegaly, systolic murmur, third out sound, mid-diastolic murmur, wide splitting of S2. Believe my words, in last 10 to 15 years, I've never seen people looking at these kind of things. If they hear a murmur, the only thing they do is echocardiography. Basic assessment. So these are the features which we look for a mitral valve regurgitation. Etiopathogenesis, I have told you already. Now let me start one by one. The intensity of Doppler signals, mitral valve flow velocities, jet area versus LA area, vena contracta, LV array dimensions. Now, this is one is the intensity of a Doppler signal of mitral regurgitations. The more cells, the more dense the signal is. The severe the MR, these cells would be more seen in the Doppler flow of the regurgitations. And whenever you have a severe mitral regurgitation, the flow velocity across mitral valve will increase. Except for the fact they should not be having associated mitral stenosis. Next important point is the shape of a Doppler flow pattern. If it's a MR, it has got to be a parabolic shape or a tongue shape. Sometimes we miss a MR jet with the aortic stenotic jet. So remember, the Doppler flow pattern has to be like this. This is a parabolic or tongue shaped. So I told you velocity increases, denser signals, and third is a parabolic Doppler flow. Then, if it's a severe, you find density to be high, what will happen to velocity? The shape will become asymmetrical. Let's show the examples one by one. This is what is jet area. We look at how much the area of the LA is being, not how much is the area when we trace this area, how much is the area of this MR jet is. Remember 4, remember 8. Less than 4, less than 8, more than 8. Mild and severe. This is what have been doing every one of us today. But this is not true because this jet is dependent on LV contraction and LA pressures. If my LV contraction are hypertensive, I'll overdoing the jet. If my LA pressures are high, I'll be underdoing the jet. So this is one factor which plays a role when we are talking of jet area alone. Now, this is what I have told you, ejection fractions and hypertension and LA pressures, the driving force. Second is, you measure the LA size also, and jet area versus the LA area is less than 20%, more than 40%. That was what? 4 and 8. Now half of it, 2 and 4, 20 and 40. So 20% the area is mild, more than 40% is severe. And there's a catch in this. You can have an eccentric jet where we add one more to the severity of a jet. Now, third point, which comes out to be a very important point, is a vena contracta. What is vena contracta? The tip of the two leaflets, the cooptation point through which the regurgitation jet is regurgitating back into the LA, is known as a vena contracta, and this is found to be very specific for mitral regurgitations. So colors, Nyquist limit 50 to 60, and you measure the difference through those closed valves from where it's regurgitating back into LA. And this is AML, this is PML, and this is the vena contracta of this patient. Less than 3, more than 6, or more than 7. Some people believe in 0.6, some people believe in 0.7. That is what vena contracta is. Now look at this vena contracta in this patient. The leaflet is billowing back, no, not billowing back, the leaflet jet through which MR is happening. Last, we need to look at the secondary signs of MR. What will happen to LA? It will become bigger in size. What will happen to LV? It will be bigger in size. So the diameter is more than 60 60 centimeters, 6 centimeters per meter body surface area, and systolic, and end. This is written a little wrong. This is end diastolic, this is end systolic. Systole would be smaller. Let me correct. If the LA size is more than 60 per meter body surface area, 60 millimeters, or 6.1 meter, 6.1 centimeter per meter square is severe. If end systolic is more than 4.5, it's considered as severe. And end diastolic dimension more than 7 is considered as severe. And then finally, LA size more than 5.5 centimeters is considered as severe. Mean to say that we look at the LV-LA size. If they are bigger, obviously they are better. All right. So let me comprehend what we have seen in this slides of 2026 as far as the basic things are concerned. We look at the density of a signal with increased flow velocity. We look at the area, 0.4 and 0.8. We look at the jet area versus L area, 20 and 40%, and vena contracta, 0.3 and 0.6 or 0.7. And last, we saw the LV-LA size. So let me add that LV-LA size. And that's what is your level to understand the severity of MR is. I'm not going to go into detail of this. I say this is a method used till 2014, but they're still being used in 2026. So in 26, I will have to go for secondary level. Obviously, what I start looking at is, I look at these 3 parameters: regurgitant volume, regurgitant fraction, effective regurgitant orifice area. And why do we look at all these kind of things? We look at a regurgitant volume, regurgitant fraction, effective regurgitant orifice area by cardiac MRI also to prove it when we are in doubts. So I'll stop over here and take your questions as far as the MR is concerned. At level 1, that's what I'm talking of. I'm not talking of a level 2 or level 3. I'm just talking of level 1. So I'll not stop my presentation. You can raise your hand so that I'll be able to reply your questions. First question comes from Dr. Satyam Sadana from Jalandhar.
Good evening, sir.
Good evening, Satyam.
Sir, can you please show me again the vena contracta part? I'm not
Sure.
able to understand that.
Can you see the slide?
Yes, sir.
So what do you see in this slide?
This regurgitation.
No. What I'm trying to show this slide is, this is a plaques view. This is LA. This is RV. Sorry, aorta. This is LV. And these are two leaflets through which the jet is originating in systole. So we look at these two jet, and through which this jet is happening, we measure this jet in systole or diastole. Systole. When the LV contracts, the blood will flow back into the LA. And that's what we measure. That is vena
Vena
contracta.
contracta.
Correct?
Yes, sir.
And this is a very important parameter. At your level, somebody asked me, what are the two signs you would like to put in when you're talking of severe mitral regurgitation is, I'll say the first point is LV dilatation. The second point is
Vena contracta.
MRVC, mitral regurgitation vena contracta in plaques view.
Okay, sir.
Correct?
Okay, sir. Okay, sir.
All
Okay.
right.
Thank
Go
you,
ahead,
sir.
doctor. Next is Jabhai. Sachin, go ahead.
Sir, we
What,
need
what
to
was your roll
measure.
number? You asked the question, previous one?
Sir, 13, sir.
13. Dr. Satyam Sadana Jalandhar.
Ji, sir.
Go ahead, dear.
Sir, we have to measure the width of the vena contracta or length of it getting regurgitant into the LA.
No. We have to measure between the tip of the leaflets.
Between the two tips.
Antero-posterior diameter. Look, can you see this slide? This is the anterior part, this is posterior part. So
Yes.
antero-posterior diameter of the regurgitant colors.
Okay.
And
Got it.
Nyquist limit has to be 50 to 60. If you increase the Nyquist limit, you will reduce this width. If you reduce the width, the color, if you reduce the Nyquist limit to 30 to 40, this will become bigger. So Nyquist limit over here has to be 50 to 60. Okay?
You can adjust that Nyquist limit.
On a machine, you can adjust Nyquist limit. There's a button on adjusting a Nyquist limit on a machine. Every machine comes with a standard Nyquist limit. This is a button with the name of scale to change the Nyquist limit.
Sir, at which part of systole?
Mid, early to mid. Avinash, early to mid, or wherever you can see the best systole. Early to mid.
Just between the leaflets.
Just between the leaflets. You see the next example. See the example?
Yes, sir.
Now, in this patient, if you look carefully, this is a red color over here. So it is at the mid systole. We are measuring the vena contracta. This is very small. When you have a severe MRZ, this vena contracta will be quite big.
Can we measure here, sir?
Here, no, it's not possible. It's a static image there. All right. Let me just try to show you. Can you stop sharing this slide for a minute?
Sir, can you show me some more examples of vena contracta, how to measure?
That's what I'm trying to do, man. Give me a second. System is taking a longer time. Just give me a breathing minute. Okay, it's booting up. Let me take other people questions. Dr. Sanjay Narayan, roll number 16. Dr. Sanjay, go ahead.
Good evening, sir.
Good evening.
Sir, can we grade MR by eyeballing?
Many people they ask this question. I think like 1/3 of LA, 2/3 of LA, 3/3 of LA. In four chamber view, we call them as mild, moderate, severe.
Thank you, sir.
Dr. Sunil Kumar Jha, 18, only online. Dr. Jha.
Sir,
Question.
my question is regarding coexistent eccentric AR jet. If it is due to right coronary cusp affection and the regurgitant jet hitting anterior mitral leaflet, can it affect vena contracta of MR, making the reading fallacious?
Dr. Jha, your question is pretty correct, but this is the question which you asked is the MR jet happens to which chamber?
MR jet from ventricle to aorta it is going, sir. In the aorta,
MR jet is from
atrium.
atrium,
From
correct.
atrium.
And AR jet is?
AR jet is it is coming from aorta to left ventricle.
So,
Left ventricle, sir.
so
I mean to say the origin, the flow convergence zone, there is 0.05 second this isovoluntary contraction time.
there are two different
Diastole
things. MR jet is at mitral valve level. The aortic regurgitation jet is aortic valve level.
but the eccentric jet due to right coronary cusp fracture that impinges on anterior mitral leaflet. And
Fine, if it's impinging the antemitral leaflet, no doubt about it. But in those cases, when you have MR and AR being together, we are not utilizing this particular modality of vena contracta.
Okay, sir, that I wanted.
Then
Thank you, sir.
we utilize volume status, like we are looking at a regurgitant fraction and a volumes. And to tell you very honestly, in those kind of cases, I always need the help of a cardiac MRIs.
Okay. Thank you, sir.
All right. Is that okay, Dr. Jha?
Sir, okay, sir. Means vena contracta is not to be relied upon if there is
MRI?
coexistence.
No. Cardiac MRI.
Oh, cardiac, sir.
We are coming with another channel on a Drop Institute. Like it will start getting activated in a month's time. That's a paid channel which are coming up. You'll find all these things on that paid channel. On Saturday, I'll try to get it recorded over there. I'm delivering a talk in Kathmandu, multivalvular lesions. How to assess them, how to manage them. It's not a question of assessment today. It's a question of management also. Suppose you have an MR and AR, what you will do with this subset of populations? Based on our pathophysiology, we'll try to manage these subjective populations. If MR is dominant structure, obviously, if MR is of a flail leaflet, I'm not going to do anything just to put a tear, end-to-end repair.
Sir,
can we do in multivalvular lesion in place of cardiac MRI, 3D echo? 3D echo
3D
can help.
echo is helpful, but 3D echo does not give you volumes. Avinash, if I'm looking at a multivalvular lesions, suppose I have to establish what is my mitral regurgitation is, correct?
Correct.
So what happens in mitral regurgitation is I have to look at regurgitant volume into the LA.
Okay.
So how do you get a regurgitant volume into LA in presence of AR? Because the amount of blood which is flowing through LVOT, the amount of blood which is flowing through mitral valve, then that's the only thing which we have in our parameters. If you have an associated aortic regurgitation, that pictures become really redundant. That's what the problem with multivalvular lesions is. At one time, at one place, we have to come and stop. Look, we need something more than this.
What will help cardiac MRI in these cases?
Cardiac MRI will help. It will calculate all the volumes for you.
Only for
MR
regurgitant
in here?
volume. Okay, sir. Thank you, sir.
No, thank you. I'm just going to show you the MR, DCMP. Can you see my application?
Yes, sir.
I hope I'm able to get some MR. Oh, beautiful. Excellent. So what I'm going to do is I'm going to stop right over here, freeze, and look at my cursor. This is in diastolic. So I'm going to go back frame by frame. So I'm at the maximum regurgitation jet cursor. This is a little calcified valve. All right. So this is at almost at end systole, not a mid systole. Let's go back a little bit more. Yeah. Now you can see what is my jet width is. Avinash, this is for you. You asked this question for me.
Sir,
So I'm going to zoom up now. Let's see how much I can zoom it. Correct? Now I'll switch off my colors. Colors gone, colors on. So this is a place from where these colors are originating. So colors on. And now I'm going to caliper. And I'm going to measure my vena contracta.
between these two calcific
Colors,
points.
colors, not calcium, colors. Let me take my caliper again. Between these two colors, 0.4, 0.3, 0.4. Not the tip. Don't go into that white spots. Now see it again. Let it play. We have to look in between the leaflets through which the color is happening. So I'm going to freeze it to you. This is now happening. So I'm going to freeze for you. Then move this cursor at the appropriate location. Correct. Now this is almost a situation between this color and this color over here. So I'm going to take a caliper and this is a color over here and this is a color over here. 0.3. It's mild approximately. And let me see that if I must. Yeah, it's the same thing. We have measured in another zoom picture, 0.5, 0.4. So here is measured. It is little overestimated because it's 0.4, something like that. So that's how we measure a vena contracta.
Sir, in calcific mitral valve leaflets, every time I think it's varies vena contracta, varies from frame by frame.
It will vary. But in that varying, what you will do is you have to go to the maximum size.
Okay.
When you will try to let's look one more. This is predominantly mitral stenosis, not the regurgitations. I'm trying to measure vena contracta, but this is not correct because it's a stenotic lesion. Because if you look at carefully, the turbulence is seen during diastole. And on top of that, if you look carefully, when turbulence is happening, Right. So we are in diastole right now. The blood is flowing from LA to LV, and you see something like pizza kind of a thing on the atrial side. Now see when it's playing. Can you see this pizza kind of a thing which is happening in atrial side?
Yes, sir.
So wherever you see a pizza, that's a dominant lesion. If you see a pizza in LA, it means mitral stenosis is dominant. And you don't see anything in regurgitation lesions. So I'll stop and take some other questions. Somebody has got one more questions. I'll exit. I'll stop sharing first. All right. Dr. Abhishek Ganesh Kesarwani, roll number 5.
Good evening, sir.
Good evening, Abhishek.
So, if the patient is having acute MI with preserved ejection fraction
Okay.
and the patient is having MR, so how can we know that the MR is due to MI only or some organic cause, other cause?
Acute MI, what do you mean by acute MI?
So, Miss patient is having acute coronary syndrome and but at the same time is having preserved ejection fraction.
Preserved ejection fraction could be 45%, 50%, but he can have a wall motion abnormalities. Your question should be better modified if the patient has got acute MI with no focal wall motion abnormalities and development of MR is present. Correct?
Yes, sir. Yes,
How
sir.
do we know that it's ischemic or non-ischemic? Give him a sorbate and find it out. If the MR disappears, ischemic. If it does not disappear, it's non-ischemic. Second question is, you have an interval MI, your ejection fraction is about 45, which is mildly reduced, and you got a severe MR. Again, in that question, acute MI, if you happen to see a wall motion abnormalities, the teething of the leaflet of mitral valve lead to mitral regurgitation. I showed you one example, something like this.
Okay. Yes, sir. Okay. Thank you, sir.
All right. Gautam,
Sir, good evening, sir.
good evening, Gautam.
Sir, my question is, sir, sir, the VC, MRVC, can you measure in fourth chamber view also? Because sometimes
You're overestimated.
it was okay. Because in some plaques it is not clear, sir, but in fourth chamber it's very clear.
Yeah, it is. You can do it. Some people they do it, and especially the Europeans are very fond of it, but they overestimate the vena contractum.
Okay,
You
sir.
look, the principle of a color is when we are perpendicular, we underestimate it. When we are parallel, we properly estimate it. The same thing happens if the dimensions has been made in plaques view, where we try to underestimate these important things.
Okay, sir.
Dr. Jigar.
Good evening, sir.
Good evening, Jigar.
Sir, you have told about Z area. Can you show me how to measure the Z area practically, sir?
Okay, I'll do that. Sure, no
Okay,
doubt
sir.
about it. Can you see my machine?
Yes, sir. Yes, sir.
Okay. This is a patient who has got an MR. So let me just hold on, stop it for you and get a maximum MR. You will agree this is the maximum MR?
Yes, sir.
So I'll go to caliper, take my area, trace, then I'll start tracing my MR. What was the dimension? 4 centimeters square in 8 centimeters square. So this is
Yes,
6
sir.
centimeters square. This is moderate.
Okay, sir.
Now I have to measure my LA size also. So let me measure my LA size. 20%, 40%. So LA size is 16 centimeters square. So this is 6 centimeters. 6 divided by 16. 6 bar 6 18. About 25-30%. So again moderate.
Okay. So both Z area and LA area.
LA.
Says okay, sir. Okay.
6 divided
Thank
by
you, sir.
16 is approximately 25%. 6 दूनी 12,
Yes.
3 बच गया 6 पंजे 30, 25%.
Yes. Yes, sir. Okay, sir.
Sir, this method is always acceptable?
No. Now, what is the fallacy of this method, Avinash?
Sir,
Look, the fallacy of this method is this MR jet is dependent on LV contraction. If my LV function is poor, I'll underestimate it. If my LV is hypertensive, it's like afterload is very high, I will overestimate it. Then LA pressure is also makes a difference because MR jet is happening from LV to LA. Normal LA pressures are 8 to 10. If my LA pressures are high, so what will happen? Because this driving force will be pushing against the pressure. So we'll be underestimating it. So this method is not always true. The best method at your level, I can say, is always look at what? Vice Chancellor. What is Vice Chancellor?
vena contractor.
Vena.
VC.
VC. Vena contractor. Now look at this patient. Very beautiful example. This lady has got a significant mitral stenosis. Look, the pizza is happening towards atrial side.
Then in
Correct.
which condition it is more reliable?
What?
Jet area.
Jet area is more reliable when you have a normal LV systolic function, normal LA pressure, normal LV pressures. When you have blood pressure 120/80 and diastolic flow pattern is normal or grade 1. But majority of people, they look at this Regurg by mild, moderate, severe just by looking at this. They don't even measure. If you have to ask me like, sir, what is my MR is? So I'll just show this. This is sir mild to moderate. While this mild to moderate is, if you look at carefully, what exactly is happening? The jet is touching to
Posterior.
no, not posterior.
Eccentric.
This is eccentric. So what do people do? You know, they'll divide this arbitrarily. 1/3,
2/3.
2/3.
Yeah.
If it's hitting till this point, this is moderate, mild to moderate. Because majority of people, oh, he's mild to moderate, mild to moderate. So this is like, because we are not going to measure MR jet in every person. You know? Like I'm going to do all calculation of mitral regurgitation when I'm looking at the mitral valve per se. This is not mitral valve per se. This is mitral valve per se, no doubt about it. This is the lady who had got all the 4 lesions in the heart. And you know, how did I pick up this lady? Because she was having persistent cough, and the history was whenever she used to lie down and she used to be breathless. And she, not breathless, she started coughing. Oh, she got tons of antibiotics. And she was quite young. And I said, Miss So-and-so, I want to do your echo. Oh, she was little amazed, like, Dr. Gupta, why do you want to do my echo? I said, I'm not going to do it. If you're afraid of it, my colleague, who says she's a female, will do it. Then we agreed, and she found to have a MS, MR, ASAR. And what we did, we started decongesting her. The cough disappeared. And we are managing her now for last 4 to 6 years. She comes in once in 6 months, once in 1 year. Anyway, forget about those kind of a thing. But this is how it.
The cause was rheumatoid.
Rheumatic heart disease, man.
Okay, sir.
RSD. Look,
Yeah.
look at carefully. Even tricuspid leaflets are thick.
Yes, sir. Yes.
And she's just 30 max to max. Like, I don't know like what happens to your city, because I'm very afraid of females all the times when they come for echo.
And sir, you are giving penicillin to the patients. The penicillin started to the patients, sir.
Till 35 years of age. Or last episode, 5 years. We very rarely see a acute rheumatic fever in this city. Very rare. And majority of patient, what we are seeing is like they come at the age of 35, 40 years. When penicillin prophylaxis become redundant. Anyway, let's cut down this story short because we have to go one more topic.
Good evening, sir.
Good
Roll
evening. Go
number
ahead.
3, sir. Roll number 3, sir.
Okay, go ahead. Dr. Nilomani.
Shailendra, sir. Shailendra.
Shailendra. Go ahead, Shailendra.
Sir, what is display and what is its significance, sir?
Splay is
Display.
splay is the
Yes, sir.
significance is the jet when it comes out of the mitral valve, it get
Yes, sir.
entangles into it.
Okay.
It gets into the entanglement in the leaflets itself. I showed you that picture. Let me show you again.
Yes, sir. Please, sir.
Because that is a very important condition. Splay is a very important condition. And to be very sure about the splay, what do we do is, we
Yes,
always do a transesophageal echo in the subset of populations. I'll have to open a file. Just give me a second.
Sir, wall hugging jet and display are same or different,
No,
sir?
wall hugging jet is different. I showed you Conda effect. That is wall hugging jet.
Conda effect is wall
Wall
hugging jet.
hugging jet.
Okay, sir.
Yeah, beautiful example. I could locate for you.
Yes, sir.
Can you see this?
Not able to see, sir.
Okay. Just then give me a sec how to do it. Just allow me a few seconds.
Okay, sir.
Sometimes I'm always thankful to all of you because sometimes you make me something different. Like you ask me a question in such a fashion that I'm able to show you really different things, and that becomes really helpful in other future classes also. So this is what I was. In fact, I have just loaded slides of display because somebody asked me, and I loaded the slide. And those slides I can show you very well today. Just give me a second. No, look very carefully. You can't see them right now. I have to share with you. Just a second. Now see, what do you see now?
Yes, sir. Able to see.
Look, this is a severe MR jet. You can see a jet over here, but
Yes,
it is
sir.
wrapping around the mitral leaflets.
Okay, sir.
So that's what
Sir,
is
is
play.
it present? Sir, it is present in severe MR only.
It is present in severe MR. We did a transesophageal echo in this patient. It was posted
sir.
direct to severe MR. And in fact, you can see a MR in this patient also, severity. Now
Yes.
see this severity?
Yes, sir.
Like it was such a fast that you could not pick it up. Let me just play this slide for you again.
Yes, sir.
Now, can you tell me, can you pick it up?
Yes, sir.
No, sir.
No, sir.
Most of the time, it could not be picked up.
So this is what splay is. But the diagnosis was made because the jet was wrapping around the mitral valve leaflets. This is splay.
Yes.
And look at the severity of a jet.
Yes.
Despite severe, the LA is not dilated. Now look, the LA is almost as big as RA. In fact, smaller than RA. No, RA is smaller. LA is not huge. So this is like maybe like God is trying to prevent a severity of MR by doing a splay. It's wrapping around the mitral leaflet. It's not putting a lot of efforts on the LA. So that could be one reason.
Okay, sir. Thank you, sir.
Right.
Sir, how can raise doubt, sir, this is severe?
How did we doubt it was severe? You want to ask that?
Yes, sir.
हमारे दिमाग में क्यों आया ऐसा severe? Because when we saw this leaflet which was wrapping around in this. Look, this is not a normal MR. Look, Avinash, look, everything is in the leaflets. Look carefully. जैसे valves के अंदर से colors निकल रहे हैं. और second thing is
looks like perforation.
And look, perforation would be away from this coaptation point. Second important part was we see some amount of regurgitation jet over here. Unless until I could stop this slide and show you the regurgitation jet, you cannot pick it up.
सर हार्ट रेट रिड्यूस करके देख सकते हैं फिर से सर?
Heart rate reduce करके देख सकते हैं. Heart rate से you will see a better. That's what you mean to say.
Yeah, this yeah.
Heart rate 7 could be. I've not done that, but maybe next time let me do it.
Okay.
All right. So Dr. Rupali Jineshwar, roll number 13. Rupali, go ahead.
Sir, good evening.
Good evening. Good evening.
Sir, pulmonary venous systolic flow reversal is indicator of moderate or
severe.
severe.
रूपाली छोटा सा एक सवाल समझो. मेरे एलए के अंदर ब्लड आ रहा है पल्मोनिक वेन से. ठीक है, ये मेरा एलए है, नीचे से ब्लड आ रहा है. ये मेरे माइट्रल वाल्व्स है, टिप पर माइट्रल वाल्व्स है. अगर उसका जेट इस पल्मोनिक वाल्व को हिट कर रहा है, इट मींस पोस्टीरियर पार्ट को हिट कर रहा है, बिल्कुल आरए की एलए की रूफ पे टच कर रहा है. सो व्हाट इज सिवियरिटी? सिवियर.
ओके,
ये तो नॉर्मल फंडामेंटल है. और एमआर जेट कब होता है? सिस्टोली में, डायस्टोली में?
सर
सिस्टम.
सिस्टोली में.
देखो लड़के वो देखते ही लड़के बोलना शुरू कर देते हैं. प्रॉब्लम ये है. अभी डॉक्टर जिगर क्वेश्चन पूछ रहा था, कोई लड़का नहीं बोला. एमआर जेट सिस्टोली में होता है,
सिस्टोली में
सिस्टोलिक ट्रंकेशन होगा.
Okay. Thank you, sir. And one more question.
Go ahead. I'm not in a hurry.
Sir, in case of atrial fibrillation,
okay.
Sir, is the same method by which we calculate MR, or is there any other?
Vena contractum. Number of times we utilize vena contractum. और एमआर जो एट्रियल फिब्रिलेशन का एमआर होता है ना, वो सीवियर नहीं होता, मॉडरेट ही रह जाता है.
Okay, sir. Thank you.
Thank you. All right, guys. Next is Dr. Pooja Kiran, Virar, Maharashtra. Pooja, go ahead.
Hello, sir.
Hello,
what is difference between congenital mitral valve disease and rheumatic heart disease? So how we know?
Pooja, congenital heart mitral valve disease would be what?
Means, sir, congenital mitral valve, MR, MS, like that. Mitral valve prolapse. So how we differentiate this is congenital problem and this is rheumatic?
Pooja, the most important rheumatic difference, the most important difference in rheumatic heart disease is when valvulitis happens, regurgitation will happen. Correct? And there'll be a beaded appearance on the mitral valve leaflet tips. beaded appearance. Just a minute. Let me just.
Like hockey stick appearance?
No.
Or
Hockey is a healed lesion.
okay.
Stenosis.
No, it's a beaded appearance. जैसे मोतियों की माला होती है ना, ऐसा हमारा
Okay.
हार्ट वाल्व हो जाएगा. Let me see if I have that acute rheumatic valvulitis valves. And if it's a chronic, when the inflammation becomes settled down, so क्या होता है? वो स्कार बनेगा. स्कार बनेगा तो जो AML की लीफलेट की टिप्स हैं उसको हॉकी शेप बना देगा.
Okay.
भाई
Okay.
लीफलेट्स के ऊपर कॉर्ड्स लगी है. कॉर्ड्स जब हील्ड होंगी तो छोटी हो जाएंगी कॉर्ड्स. जब कोर्ड छोटी होंगी तो वो वैल्व को पूरा खोलने नहीं देगा. If you happen to see a dome-shaped leaflet, 99.9% it is a rheumatic heart disease.
Okay.
If you do not see a dome shape, you think of something else.
Okay.
Acute rheumatic valvulitis. I have a picture. Just give me a second. I should be able to show you acute rheumatic valvulitis. It's a very classical beaded appearance on patients' leaflets. We don't see them nowadays. We hardly see them because, say, first of all, hygienes have improved, things have fallen down, the number of rheumatic fevers have gone down dramatically. Second thing is they are happening in the cities which are away from metropolitan cities, in smaller villages, now tier 3, tier 4. And majority of these, they go unrecognized. Why they go unrecognized is because moti jhara, typhoid. एवरीबडी सेज अरे इसको मोती झारा हो गया. एक क्वैक मिलेगा, कोई डॉक्टर मिलेगा, वो उसको लेंस लगा के देखेगा, छोटे छोटे दाने हो गए, मोती झारा हो गया. तो इसमें ये हकीकत है, हमारी प्रैक्टिस की हकीकत है ये. अच्छा, सेकंड चीज है, दवाई दो ना दे उससे तो ठीक हो ही जाना.
क्योंकि सर कभी कभी ओपीडी में ऐसे पेशेंट आते हैं जिनको MRMS होता है बट हिस्ट्री ऑफ फीवर ऐसे कुछ
अब
नहीं रहता है.
अगली बार पूछना सबको मोती झारा हुआ हो. खोदना पड़ता है. हम लोग एको लैब रन करते हैं, विश्वास मानोगे, नंबर ऑफ टाइम्स आज एक पेशेंट को किया हमने एको, उसका हमें प्रोस्थेटिक वाल्व दिखाई दे रहा है एओर्टिक पोजीशन पे. वो बताने को तैयार नहीं है. दिस इज टावर हुआ हुआ, सर्जिकली टावर हुआ हुआ है, हमें लग रहा है टावर है ये. और मैंने पूछा क्या हुआ, कहती कुछ नहीं हुआ जी, मैं तो ठीक ठाक हूँ, मेरे को कोई तकलीफ ही नहीं है. मैं तो आया क्यों यहाँ पे? अपन आज दिस क्वेश्चन, घूमने आया है क्या? तो तब कहता सर वो किसी ने मेरे मतलब हार्ट के अंदर वाल वाला छल्ला डाला था. मैंने इससे पेपर पूछे, कहते जी कौन से कागज, वो तो खो गए. And then we did a 3 dimensions echo and we spent a lot of time, found out that this was not now normal aortic valve, it was a tower, trans aortic valve replacement was done. आज वो कागज शाम को कागज भेजता है कि सर ये मेरे वाल्व्स के कागज है, व्हाट्सएप करता है. अरे मैंने पहले कहा थे भाई, सो क्यों रहे थे तुम? तो ये बड़ी कॉमन सी चीजें हैं. नथिंग रॉन्ग अबाउट इट, यू नो, लाइक दिस इज लाइफ, वी हैव टू डील विद दीज पीपल. बहुत अच्छा है वो. आई एम नॉट एबल टू लोकेट इट बिकॉज दैट इज एक्सलेंट, वेयर वी कुड डेमोन्स्ट्रेट अ beaded appearance. And the patient had come with the same high grade fever, and we could see a significant mitral regurgitation with beaded appearance of the mitral valve leaflet. I'll just write it down. जैसे मैंने पिछली बार भेजा था, फिर भेजूंगा ढूंढ के.
Okay.
I hope all of you got those slides, you know, which I sent you. 2 questions were asked by 2 intelligent people. भेजता हूं मैं आपको ना. I just jot it down. I'm sorry I couldn't locate them in my armamentarium. अब देख बहुत समय से देखा भी नहीं. Last अविनाश जी आप रह गए, और क्वेश्चन बाकी है आपके, पूछो फटाफट।
Sir, what is the criteria of coaptation size for mitral clip?
आओ, पूरी क्लास पढ़ाएगा तू? नहीं, पूरी टॉक है ये। लीफलेट साइज है, लीफलेट गैप है, 4-5 फैक्टर्स हैं उसके। अभी रुक जा, बाद में करेंगे इसको।
और सर एक और छोटा सा है, is mitral clip suitable for all primary severe MR?
All primary, yes. Example, you tell me the example. I've seen recently one mitral clip being done in acute MI, ruptured cord, severe MR, acute MI, severe MR, and we could save a patient by doing a tear. और बहुत बड़ा आदमी था, नाम नहीं बताऊंगा, माउंट आबू में रहता था। Persistent heart failure, non-improvement of MR. चलो कोई बात नहीं, चलते हैं आगे।
And sir, last question is, what is the role of tenting area, tenting height, coaptation distance only for mitral clip or somewhere else?
सब जगह काम आता है। एक क्लास तेरी सेपरेट लूंगा, थोड़ा सा आज छोड़ दे मेरे को, ये बच्चे सब कंफ्यूज हो जाएंगे इन सबको पढ़ के। तो कहाँ लेवल 1 में आ गया, तेरा लेवल 3 था। चल एक क्वेश्चन का जवाब दे दे, तो बात तेरी बात सब समझ जाऊंगा। दे सकता है वैसे, तो कोई खास बड़ी बात नहीं। पूरी टॉक है अविनाश, आई कैन गिव यू अ कंप्लीट टॉक ऑन दिस। All right, that guys, move on to aortic regurgitations. Like this is a pathology which is little different than mitral valve, which is not really different than mitral valve. So I hope you are able to see my slides. My first slide is, what are the issues in aortic regurgitations? We have anatomy, classification, etiology, mechanism, evaluation of severity, limitation assessment of severity, how much we should depend on. Forget about all these things. This is what you need: anatomy, classification, etiology, and evaluation of severity. So it has got 3 cusps. All of us understand: left, right, and non-coronary cusp. And this is where the cusps are. They'll tell you about the right is the right coronary artery, left is left coronary artery. This is non-coronary artery. And second important thing is how these cusps are placed in relations to mitral valve, tricuspid valve, and here is the aortic valve. And whenever we look at a 3 dimensions picture, this aortic valve is at 0 degree, 12 o'clock, not 0 degree, 12 o'clock. So that this is up. Let me just do it for you.
एक्सक्यूज मी सर।
Go ahead.
सर इसका रिकॉर्डिंग हो रहा है?
हाँ हाँ बिल्कुल रिकॉर्डिंग हो रहा है। Yeah, recording is going on, don't worry. थक गए क्या सुनते सुनते, या सिर के ऊपर से जा रहा है?
नहीं सर, आई कैन नॉट सी हियर इट्स इज रिकॉर्डेड, दैट्स व्हाई आई आस्क्ड।
Oh really? स्केयर कर रहे हो आप मेरे को। Are you able to hear now?
Thank you, sir.
Thank you. So let's look at the etiology first. Same like acute, same like chronic. Now, acute is endocarditis, aortic dissection, blunt chest trauma. Chronic is either rheumatic, calcific, bicuspid, systemic inflammatories. And then we have a whole lot of other things, like patient develops a Marfan syndrome, patient develops aortic aneurysms, they become hypertensive, or they develop aortotitis. And one more variety is iatrogenics. So I'll show you that iatrogenic. Now this is very clear. You can see this patient who is suffering from what? Anybody? अविनाश जी बताओ क्या सफर है? Vegetation. Patient will present with acute aortic regurgitation. So treatment is surgery. This is another patient of our lab where this young man came. This is almost 10 years down the line. The young man came, and when we saw that he was running fever, and if you look carefully, what exactly has happened to this patient was his non-coronary cusp is gone. Here is a right coronary cusp, here is a non-coronary cusp. You can't see a non-coronary cusp. And when we put in a color, we could see a significant aortic regurgitation. You can see a significant aortic regurgitation over here. And we did a transesophageal echo, and this was truly aortic regurgitation because of infective endocarditis. Now, vegetations presenting as aortic regurgitations. Surgery. Dissection of aorta. Now you see a two aortic valve over here. One over here, second over here. God will never give you two aortic valve together. And whenever you see these two aortic valve, you always think of dissection of aorta. And this is associated with significant aortic regurgitation. Answer? What? Surgery. This is chronic. This is again a descending aorta. The dissection of aorta is in little lower side. Here is a valve, here is again a dissection. And this dissection gives rise to severe aortic regurgitations. Here, you can see a flap out here. Flap out here. Again surgery. Another example. Can you see this membrane? Nodules. This is again classical dissection of aorta. So the AR again is dependent on etiopathogenesis. Now, this is what exactly everybody is looking forward. Chronic primary aortic regurgitation because of a rheumatic heart disease. Unicuspid aortic valve. You can see a single leaflet out there. Bicuspid, left-hand side variety. So you raise your hand to left-hand side. This is the left-hand side variety of the bicuspid aortic valve. This is 3 dimensions picture of a bicuspid aortic valve. These are pictures are published in America in the G book of 3 dimensions imaging. Now you can see only 2 cusps seen over here. This is bicuspid aortic valve. Now see 4 cusps. 1, 2, 3, and 4. So it's a quadricuspid aortic valve. This is aortic regurgitation. Rheumatic again. Calcification of the aortic valve. Look, leaflets are not doming, but they have a calcification deposit on them. Age is 56 years. Then aorta has dilated. So aortic disease has developed. VSD with AR. There is only one variety where VSD is associated with AR. Doubly committed VSD. You can see this VSD over here. So etiology is important, and this is one. अविनाश जी बताओ क्या है ये? Continuous AR. आप देखो सिस्टली डायस्टली पूरा AR आ रहा है. Is that right or wrong?
Right.
Why it's happening? This patient is on left ventricular assisted device, LVAD. Look, here is the LVAD. So it's constantly sucking blood from the LV and delivering to aorta. So valve remains open throughout. Here is the LVAD. So these are iatrogenic. This is aorta. Look, tower. This is a aortic valve replacement, but transcutaneous. Transaortic valve replacement. So this is tricuspid aortic valve which has been replaced. This is very old picture. Now the aortic valve, they do not look like this at all. The images are such, they are like basically a bioprosthetic valves. Then primary, now we can understand what is primary, and then secondary. Acute versus chronic. Acute is like trauma, infections, as in mitral regurgitation is. Now coming to how do we look for aortic regurgitations when we're talking of chronic aortic regurgitations. So let's start one by one. So the first important thing for any severe aortic regurgitation is wide pulse pressure. Then come imaging of the valve, kind of it. And then comes the evaluation. The first thing is whether the leaflet is prolapsed, flared, restricted, thickening, calcification, vegetation, embryo size, or dilatation. Next point comes imaging of the valve. And when we talk of imaging, the first things comes jet width height oblique LVOT height. So here's a patient of severe aortic regurgitation. So we have a vena contracta, we have a jet width height oblique LVOT height. So vena contracta is the origin. Jet width height is how much big this height is of the AR jet is in comparison to LVOT height. LVOT is roughly about 2.1 to 2.2 to 2.2. And look at this jet width is 1.71 centimeters, almost more than 60%. So from where the leaflet that happens, this is jet width and this is LVOT height. More than 65% is considered as severe, less than 25% is considered as mild. Then comes vena contracta, same as we were seeing in mitral regurgitation. We were seeing between the mitral leaflet tips, here we are seeing a aortic regurgitation jet in between aortic leaflet. That was in systole, this is in diastole. Again, the values are 3, 6, less than 3, more than 6. Some people say that 7, but again 6. So at your level, remember at 6 for AR and 7 for MR. Then next thing comes is pressure half time. You put a continuous wave Doppler across the aortic valve. So you get a forward flow, you get a regurgitant flow. You measure this deceleration time from beginning to end. This is how much time it takes for the pressure to drop to half. That is pressure half time. And very severe is 200 milliseconds, more than 500 is mild. And last very important thing is we go to ascending aorta, we go to descending aorta and put a cursor into the descending aorta flow. And see how much is reversing back into the LA. What is collapsing pulse? Why the pulse pressure is very high? Because the blood is regurgitating back into the LV cavity from aorta. So we do the same thing by putting a pulsated Doppler sample in the descending aorta and look at how much is this planimetrized this descending aorta. VTI 22 and diastolic velocity 22. And even you can see in descending aorta also reversal of flow. And last, the most important part for any particular thing is the LV size. I'm not going to touching all these things because it's not your level again. So what we look for severity is, we look for first jet width height oblique LVOT height. There was jet area versus LA area. Here is a jet width height oblique LVOT height in plaques view at aortic valve. There vena contracta, here is a vena contracta. And third important point for you is we look at a pressure half time, less than 200, severe, more than 500 is mild. And finally is to finally nail the diagnosis of aortic regurgitation is. Look at a descending aorta flow velocity. Holodiastolic. Holo means through and through in diastole. Trace this Doppler spectrum pattern. End diastolic velocity more than 22, and diastolic velocity, and VTI is 22. And this is known as severe aortic regurgitations. But mind my words, if your BP is 130 by 60, I'll take this as a factor for severe aortic regurgitation. If my BP is 120 by 80, I'll have to go back and see whether my calculations are correct or wrong. Because clinically is the most important thing. I'm still saying these things again and again. Severity of ARZ is the most important thing, is a peripheral signs. So points to remember is vena contracta, jet with height oblique LVOT height, pressure half time, and finally holodiastolic reversal of flow in descending aorta along with LV dilatations. And that's what will give you the severity of aortic regurg. Let me put them in together. This is dimensions more than 70 centimeters, or we say more than 32 millimeter per meter body surface area. Continuous wave Doppler signal dense, forward flow velocity will increase. AR jet with height, with the LVOT height more than 65%. AR pressure half time is less than 200 milliseconds. Abdominal reversal of flow more than 22 centimeter end diastolic and VTI, and vena contracta more than 6 or 7. Some people, they are little vary about 7. Some people talk of 6, but we have to come to a figure, because last time when we were making a decision, some people wrote 6, some people wrote 7. So let me just say, I'll say 7. 6 is the correct one. Well, all right, guys. So these are other things like pizza. Then second is we look for volumes, calculation of regurgitant volumes. Then we look for, there's one more variety, moderate to severe aortic regurgitations. So at your level, let's talk of all these things important, which are visual assessment of multiple views, vena contracta, then pressure half time, jet with height of the LVOT height, and LV dilatations, and descending aorta reversal. This is fairly good enough for you. Forget about a pizza, everything is there in this. Questions? I know a little hurry on this, but this is virtually the same evaluation as we do in mitral regurgitations. Okay, Dr. Deepak from Madhya Pradesh, road number 18. Deepak, go ahead.
Yes, sir. In case of aortic regurgitation, when we calculate PHT, where to place the sample volume exactly?
In when we are measuring a pressure half time is, we have to keep a sample volume in the 5-chamber view at the level of aortic valves. And we are not keeping it a pulse wave Doppler spectrum, because we'll be putting in a continuous wave Doppler spectrum.
Okay, sir. What is the exact site before the aortic valve or just after the aortic valve?
Continuous wave Doppler spectrum would be across the valve. There is no site specific continuous wave. It just it scans across the whole LVOT.
So in the jet, we have to place the sample volume at the jet. Jet is coming from aorta to LV.
Aorta to LV.
So
wait,
where to?
I'll just give me a second. Next is, I will come back to next to the people. Just give me 2 minutes. Can you see my slides?
Yes, sir.
Okay. Yeah. Look in this slide, what I've done is, this is a continuous wave Doppler spectrum pattern. Like pulse wave should be at this point first. Can you see my arrow?
Yes, sir.
It should be over here. At where? In this point.
At the LVO tip.
LV, just yeah, because from where the jet is originating.
At the origin of jet.
Correct.
Okay, sir.
I'm trying to get this. Yeah. At the origin of a jet. So what will happen when you keep at the origin of a jet? You will find aliasing. Because the pressure in aorta and LVS is lot different than pressure, because we are coming in end-diastolic pressure. When LV is contracted, it has to go down below the mitral valve before this mitral valve opens. So there will be a lot of difference of pressure between LV and aorta. And look at this AR jet velocity is almost 4 meters per second. So first we'll keep in this pulse wave Doppler spectrum in AR, and then we'll have this aliasing of this Doppler spectrum pattern. Then we switch over to continuous wave Doppler. It'll give you a forward flow and this Doppler flow of AR jet. You measure from beginning to end, you will get the answer of pressure half times.
Okay, sir.
Clear?
Yes, sir. Thank you.
All right. Dr. 28. Dr. Sachin, go ahead.
So can you explain that pizza formation again?
Pizza formations for AR.
Yes.
I did not tell about pizza. I'm not talking of pizza at all.
What the MR?
Pardon?
What the MR?
Pizza MR, I'm not talking. Pizza, I've not touched at all. Pizza. Vena contractor, I've touched. I've not touched pizza at all.
You said something like pizza formation at the.
Okay. Okay. I got it. What you want to say is. All right. Let me go to archive then. What I'm trying to say was, I was trying to say, based on which side the dominant lesion is, the pizza will form. Correct? That's what I wanted to say. Let me find a dual lesion. That'll be the real answer. Yeah. Correct. What I wanted to say is, you have a lesion which has got MS and MR, both of them together. So how do you say which lesion is dominant? Correct. So in this patient, look, this patient has got MS, this patient has got MR also. And if you look carefully, if something like pizza is forming on LA side, it means my MS is dominant. I'll stop and show you. Now you see a colors jet over here.
Yes.
So this is forming in a LA side, suggesting that this possibly MS is dominant. If it's a MR, it will form on this side, opposite side.
So what exactly is the pizza formation? Thank you, sir.
The pizza is proximal isovolumic surface area. Tomorrow morning, what you should do is you have a wash basin, take a bucket of water, put in a wash basin. So as the water will go through that drain pipe, it'll form multiple rings.
Oh, yes.
And that is in medical term is known as pizza. So what we do in pizza is, let me go back and to my presentation. Stop share. I think I have to go back to mitral regurgitation to show because pizza is very good seen in mitral regurgitation rather than aortic regurgitations. So I'll stop sharing this slide over here. Perfect. This is slide number 1 to 9. Okay. Can you see the slides?
Yes.
Are you able to see or not?
Yes, sir.
Sachin, can you see the slides now?
Yes, sir.
Okay.
Yes.
So let me stop this slide for you. Correct. Now look carefully in this slide. There is a half hemisphere seen over here.
Yes, sir.
This is pizza radius. Based on this pizza radius, what we do now, I'm going to the clear. This is half of the pizza radius. So we measure this radius. Then we move this Nyquist limit towards the jet side, towards the regurgitation sides. So this becomes 80, this becomes 20. So velocity of aliasing is 20. Then we say regurgitation flow is 2 pi r square into velocity of aliasing. Then effective regurgitation orifice area, regurgitation flow divided the peak velocity of the regurgitation jet. And the regurgitation volume is effective regurgitation orifice area into velocity time integral of the regurgitation jets. So this is how we calculate recurrent volume by this PISA method. And majority of people have given it away. Why? Because there's so many of a calculation. Look, first of all, the radius itself is very difficult to calculate. Then we need visa velocity aliasing. Then we need peak velocity regurgitation jet, and then velocity time integrals. And one gets mistake, the whole thing gets haywired. So what we do instead of that, we go to direct method of calculation of regurgitant volumes. And how do we do it? The blood which is flowing through LVOT and the blood which is flowing through mitral valve, we calculate that. In LVOT, we understand we take a LVOT area into LVOT VTI. Same thing we do at mitral valve levels. We take mitral valve area into mitral valve VTI. So suppose 100 ml is happening, 250 ml, 100 ml happening at mitral valve level, and aortic valve level is only LVOT 60 ml, then regurgitant volume is 40 ml. Forget about it. You'll get completely confused over a period of time. And this we do it when we have to differentiate a patient between moderate to severe mitral regurgitation to undergo surgery. Then we put all these methods together. We do number of calculation we'll do in that patients. Like at that time, we have to spend about half an hour to 1 hour time. So say that this patient should go for surgery or should not go for surgery. I hope I'll stop over here because too much of a things which you will understand over a period of time. Let me take some other questions from other people. Dr. Sachin is done. Sachin asked a very difficult questions to everybody. Gautam Devnath, go ahead.
Sir, can you kindly demonstrate the jet height because it is confusing between jet height and BC, sir.
All right. You want the jet height? I'll come back.
Yes.
Avinash, okay, I'll ask you a question later on. So let me come back to my presentation again.
Sir, can you do the AR regurgitant volume by continuous equation like MR, sir?
Oh, AR, we are not in continuous equations. I'm trying to find a clip for you for how to measure the AR.
Yes, sir. Just show me, sir. Just a simple illustration.
Okay, I hope this picture has got it. Beautiful. So I'm going to stop this slide for you. So I'll stop at what? Early to mid system diastole. Correct?
Yes.
Now I'm measuring my jet width height at the level of LVOT. So this is my jet width height at the level of LVOT. 1.1 centimeter. Then I measure my LVOT diameter, but not in the same session because LVOT diameter would be in early systole. This is in diastole. So I'm going to measure my LVOT dimensions in early systole.
Yeah. Yes.
So this is, and
Yes.
I always measure at LVOT at the annulus level because I always feel this is more comfortable for me.
Yes.
So it's 19. So that was 12, 11, that was 19. So almost 40 to 50%.
Okay.
Moderate. Same patient, we can calculate the AR, vena contracta. Let's see how to calculate AR vena contracta. So switch of colors if you have a doubt. Now this is a leaflet. This is LVOTs over here. This is the leaflets. 2 leaflets, correct?
Yes.
So at the level of leaflets, I'm measuring my vena contracta. Let me just show one more vena contracta. Now this is better than before. So I'm going to stop it for you. Move frame by frame. Beautiful. So I use my caliber and this is my vena contracta. 5 to 6 millimeters.
Moderate. Done.
Moderate. Both of them are moderate.
Done. Thank you, sir.
Second important thing is, if you tell somebody is severe, what other point I told you? AR is severe, then LV has to be dilated, man.
Dilated.
So look at this LV. LV size is, suppose its body surface area is 1.7,
More than
46. 17, 46 divided by 17 is less than 20, it's about 28 millimeters, not even 32. So it's normal size. And then last I want to show you is, oh, this was somebody was asking the same thing. Look, this is a continuous wave Doppler across the aortic valve. And we can calculate the pressure half time. Let it can go down, I think. So it's aliasing. I can't measure it.
Yes.
I was trying to show you a
Yes.
sometimes some must have recorded and they must have forgot to record the hololastic reversal of flow in descending aorta. Because when they thought it's moderate, they'll not do it. No, not that. Anyway, this is all about aortic regurgitation. Avinash, go ahead. Your questions now.
Sir, how can approach aortic regurgitation quantification in bicuspid aortic valve where the regurgitant orifice is elongated or non-circular?
Same method. And in case you are doubt, you can do a 3 dimensions vena contracta area. More than 0.5 centimeter square.
Okay, sir. Thank you. Or sir, second question, sir,
let me answer the first question first again. Okay. If you have a bicuspid aortic valve, the fair chances is you're going to have a stenosis rather than regurgitation. Go ahead.
Sir, in case of descending aortic holodiastolic flow reversal, suggest severe AR, but color flow so indicates only moderate AR. What should do?
Doppler flow pattern.
Holodiastolic flow reversal is not.
Raise the Doppler flow pattern. It should be more than 22 and diastolic velocity more than 22.
Okay, sir. Thank you, sir.
All right, guys, any other questions by somebody? All tired, right? So I can see everybody out here. Roll number 1, Dr. Gautam Devnath is there. So I'm quickly saying 1. Okay. Roll number 1, Gautam is there. Roll number 2, Rahul Sangwan.
Present, sir.
Roll number 3, Shailendra was there. Roll
Present,
number
sir. Present, sir.
Shailendra, you asked the question. I've marked you answer questions already. Dr. Nilomani from Dima, Assam.
Yes, sir.
Abhishek was there. Dr. Dipankar Jaiswal, roll number 6.
Present, sir.
Dr. Sai Shruti, Athani, Karnataka. Dr. Shai Shruti. Dr. Parmesh Pundik Powalkar, 6. Roll number 8.
Present, sir. Present, sir.
Okay. Dr. Jigar was already there. Dr. Vaibhav.
Present, sir.
All right, Vaibhav. Dr. Vasant Kumar, Karnataka.
Present, sir.
Dr. Chinna Reddy, Andhra Pradesh. Dr. Satyam Sadana was there.
Present, sir.
Yeah, Dr. Patil Surish Sunil.
Present, sir.
Dr. Shrikant Jana.
Present, sir.
Dr. Sanjay Narayan was already there. Dr. Akash Param.
Present, sir.
Present, sir.
Deepak Kumar, Madhya Pradesh.
Yes, sir.
Sardhansh Agrawal was present from Patna. Deepak Bansal.
Present, sir.
Kalyan Bora, Jorhat.
Yes, sir.
Nibir Nath Sharma, Guwahati.
Present, sir.
Jinen Maheshwari, Kutch, Gujarat.
Present, sir.
Sanchit Bhandari, Gurugram.
Present, sir. Present, sir.
Kshitij Kumar, Noida.
झाला आता
Kshitij-
अटेंडन्स वाटते 12 वाज होते तो आता काय झोप आहे डायरेक्ट नाही एवढं लाईट नाही झोप
अरे बॉस अपना माइक ऑफ कर दो ना, क्यों शोर मचा। पढ़े लिखे लोग भी ऐसा करेंगे तो अनपढ़ क्या करेंगे हमारे जैसे यार। जिसके अटेंडेंस है वही बोलो ना। क्षितिज कुमार नोएडा। क्षितिज, आप सबने ऑफ कर दिया माइक अपना। ऑलराइट, देवजीत मजूमदार।
Present, sir.
डॉक्टर पुशान मिश्रा।
Yes, sir.
Dr. Sachin was there. Dr. Rajiv Kumar Pandey, Ranchi.
Present, sir.
Manu Kapil.
Present, sir.
Mohammad Kaleem, Saharanpur.
Yes, sir.
Aditya Ashwin Kumar Dhawale. Dr. Sagar M.K. Karnataka.
Present, sir. Present, sir.
Mohammad Amin.
Present, sir.
Syed Furqan.
Present, sir.
Present, sir.
Ayush Kumar Muzaffarpur.
Yes, sir. Yes, sir.
Rupender Singh.
Present, sir.
Dr. Joey Gupta. So I'll repeat absentees. Sai Shruti, Chinna Reddy, Kshitij Kumar.
Sir, Kshitij Kumar present, sir.
Okay. Then Aditya Ashwin Kumar Dhawale. And finally Joey Gupta. 1, 2.
Dr. present, sir.
One present, madam.
Dr. Urvil, he is seeing a patient of MI.
उर्विल कहाँ से आया? मैंने उर्विल को पूछा ही नहीं था।
Yes, sir.
अरे उर्विल का नाम ही नहीं लिया, बेटा यस कर रही हो।
16 है इसमें उर्विल, तारा को नाम नहीं है।
Online 16, sir.
अरे मैडम रुक जाओ ना, किसी और के अटेंडेंस क्यों लगा रही हो खाम खा कूद कूद के। Now online, Dr. Rachel Monica.
Present, sir.
Singh Sandeep.
Present,
Mumbai.
sir.
Akshay Kumar Gupta.
Present, sir.
Disha Vipul.
Present, sir.
Then Pooja Kiran was present. Dr. Prashant Narayan.
Present, sir. Present, sir.
Avinash was present. Surbhi Thakur.
Present, sir.
Shafiq P. Mallapuram.
Present, sir.
Present, sir.
Malik,
Present, sir.
Gedam Jitendra Navaji, Bhavik Kalpit Sangvi.
Present, sir.
रूपाली जी अब आ गई हैं आगे.
Present, sir.
पटेल चिंता कुमार दलीप भाई.
Present, sir.
दीपकृति गुप्ता.
Present, sir.
अब आ गया उर्विल, नाम बताओ. मैडम कहाँ है आपकी?
Yes, sir. Yes, sir. I'm here. Sorry, sir.
अरे आप उर्विल, आपके तो कोई लड़की बोल रही थी अभी थोड़ी देर पहले.
Sir, she was my wife, sir. I was working on patient at that time, sir. Sorry, sir.
अच्छा कोई बात, नो इश्यूज यार. काम, बड़ी अच्छी वाइफ है यार आपकी. गॉड ब्लेस यू.
Thank you, sir.
आपके अटेंडेंस भी लगा देती हैं.
Thank you, sir.
गजब गजब है, छा गए. डॉक्टर, यू मस्ट बी अ ब्लेस्ड हस्बैंड, यू नो.
Yes, sir.
डॉक्टर उसी के सामने बोल रहा है, पीछे बोलियो. चौरे अभिषेक.
Yes, sir.
Sunil Kumar Jha has asked the question. So only absent is Dr. Gedam Jitendra Navaji today. Then previous batches, Dr. Rajan Verma,
Present, sir.
Naresh Kumar.
Sir, sir, I am
हाँ.
Dr. Jitendra Gedam, present, sir.
अरे कहाँ रह गए थे आप भाई?
यही था सर, आवाज नहीं आ रहा था मुझे.
अच्छा चलो कोई बात, आ गया, चलो ठीक है. डॉक्टर राजन वर्मा हो गए. डॉक्टर नरेश कुमार जंगाड़े, डॉक्टर रक्षपाल सिंह, अजय जयराम चौरसिया, डॉक्टर कमल मालविया,
Present, sir.
and Dr. Shabir Ahmed Khan, Gantur. Chalo. Done, guys. Had a good time. I hope we were able to clear your doubts as far as this particular AR and MR is concerned. We'll send you the recordings. Go through them again and again as many times as possible. That'll be great for you. And we'll see you next week with another episode of valve lesions before we go for live demonstration. We did do some live demonstration today also, but we'll show a full live demonstrations. With this few words, thank you everybody. Take care, stay safe, have your dinner if you have not taken, or you can have a cup of tea like Dr. Sachin Bhimrao is taking right now. Bye-bye.
Or connect online to begin your journey. Visit echocourse.in or jrup.in and take the next step toward excellence. JROP Institute. Excellence in Echo Training. Empowering professionals, saving lives.